We were overwhelmed and couldn't stop ourselves, sir.
No, that's very good. That's very kind of you. So today, actually, I have to thank Juventus and especially Pradipta, Juveria, Sachin for putting this up together. And I think this is a very important day today, where we'll be discussing about acute pancreatitis. And what gives me most joy is the panelists, because this is a multidisciplinary disease which require multidisciplinary management. And to have a physician in this group is extremely important, because most of the time it's the physician that who would encounter this patient first, and then some of them will come down to the gastroenterologist, and then some of them will go to the intensivist. So I think it's great to have Dr. Debasish, and we have Dr. Parimal Lawate, who has a rich experience, more than 30 years of experience, and I think will be graced by his wisdom. And again, all the senior gastroenterologist, Dr. Neeraj Jain. Arun is a alumni from AIG. So
nice to see
again,
you, sir, after a long
we
time.
saw how he grew in his surgical career. Hi, Arun.
Yes,
so today, I mean, we'll get a taste of your wisdom and experience that you gathered all these years. Anand, my friend, and he helps us all the time. Any bad pancreatitis patient, we run to him. He is a great help to us, and of course Ruchir, I think the youngest in the group, but he is a Ruchir Lawate is a disruptor, because we were just discussing before this session opened, like we as clinicians usually get into the nutrition part of the patient, which is very important. But this young gentleman has, being a medical doctor, started a career in clinical nutrition, and that is commendable. And he had spent some time at AIG with us, and he really did great during those few months. So let us see how we can hi. So let us see how we can manage this complex disease in the first 4 weeks. So we'll take you through a case, but before that, let's see. These are the panelists they had already introduced. So let's go back like to more than 100 years. So there was an Austrian pathologist called Hans Kyrie, who for the first time had told us that the pancreas can digest itself. And that was the first knowledge that we got about acute pancreatitis, where the pancreas's own enzyme would digest the pancreatic tissue. We know this from 100 years back, but even then, why we are still struggling to find out an answer or cure to this disease? So that is the moot question today. So if we see the literature, this was a meta-analysis published several years back, which shows that mortality in the presence of infected pancreatic necrosis and multi-organ failure is more than 40%. And the figure still stands same even today, where we'll get to know that as we go through the case. And even today, we are struggling to diagnose or predict infected necrosis, try to predict and stop organ failure, try to do different fancy interventions, try to prevent mortality, and try to avoid readmissions. So this shows that even after more than 150 years of having a knowledge, still we don't know the basic mechanism, probably which is translating into this struggle for understanding more and having this kind of seminars. So let's begin with this young story of this young boy. Let's name him AP. So he's still alive. He is a young, happy-go-lucky chap, around 35 years old, obese, morbidly obese actually, with a BMI of 32. So he went on a weekend party, had a few drinks. He usually, occasionally takes some smoking. So 3 hours after binge eating in the party at around 8 p.m., he started developing epigastric pain that radiated to the back. He had greenish yellow vomiting, and he thought he was drinking and eating a lot, so could be some acidity issue. He popped in an acidity pill, which was already there in his pocket. Actually, these guys move with acidity pills and things like that. But there was no reduction in pain and vomiting, so he landed up in a local hospital early in the morning at around 3 a.m. On clinical examination, the DMO there found a heart rate of 104, blood pressure was kind of normal, 130 by 80. Saturation oxygen was normal, temperature was normal. So this is the clinical history that the doctor first encountered. So, Dr. Basu, I'd like your opinion here. You being a physician and this kind of patient would come to you first. So, what do you think this is? So how would you approach this patient? I think your mic is muted, Dr. Basu.
Yeah. Good evening, everyone. Good evening. It's a
Yeah.
proud privilege to be in such an august gathering.
Yeah.
I feel like I'm a stellar component today. The weather is also good, and it's a Saturday evening. I will start on a very romantic note. I will say that love is like pancreatitis. It starts off slow, and then it builds its intensity until you finally get consumed in so much love that you start developing cramps, violent cramps. That's what is happening to most of us in real life.
Yeah.
And that is actually what pancreatitis is. It is a word that has always been connected to not so easy. I mean, a horrible kind of a consequence that we have seen over our experience. I would, as you said, that this is a classical case where we need to diagnose just from a phone call. If a person gives you this kind of a story, you will immediately think about what is the classification of acute pancreatitis, what is the etiology of pancreatitis. So you will immediately focus your attention to pancreas and only pancreas. So this is a, 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 an obese person, and I will just come directly to why obese, because there are several ways, and today I want to make this clear to all my good friends in the world, that obesity or diabetes is the word that we are commonly using as a fad, but it is not an easy word. We need to actually give much importance to it and understand every reason why we mechanistically connect to all the 4 M's that obesity or diabetes gives us. Mechanical is the weight of the obesity, then metabolic, then mental, and finally, monetary. You'll end up in a lot of monetary distress. So acute pancreatitis, what happens is, maybe, cholecystitis, whether it's a sludge or a stone, it's whether it's a microlithiasis or stone, they cause bile reflux. So they increase the pancreatic duct pressure. So you build up that pressure, and all these, kind of a binge drink. In fact, binge drinking actually on record has not really given much of an acute pancreatitis episode. But a man who is chronically alcoholic, and with that kind of a rich food, they predispose to cholesterol-rich crystals or stones in the bile, and then crystal numbers and growth happen. So you get obese children also with biliary pancreatitis today. They have much higher likelihood of stones than sludge. And there are umpteen reasons why obesity, whether it's hypertriglyceridemia or whether it's per se diabetes associated with obesity in a person of young age. We say, in fact, I actually launched a slogan called "Umr hai 30 saal, madhumeh ka jaach har saal." That's this was translated in Hindi by Javed Saab from Bengali, and we are trying to revise this "Umr hai 25 saal, madhumeh ka jaach har saal." That diabetes and obesity, they are obviously hand in hand. So whether it's hypertriglyceridemia, which is high, whether it's a high-fat diet and cholelithiasis, whether it's the incretin-based treatment that is being given for diabetes, causing questionable beta cell hypertrophy somewhere, or today we have the GLP-1 receptor analog, which cause osteoblastosis.
Yes.
They can all cause obstruction and pancreatitis. So as we started this conversation, that this gentleman whom we meet today, we now need to approach this case as a case of if we straight away go into as a case of pancreatitis, how do we diagnose? So we talk to the person. This is a critical case, so he's suffering from this acute onset. We first and the foremost is we need to admit, we will not wait in this kind of a setting. The gold standard, of course, is diagnosis and evaluation for the severity of the acute pancreatitis. So there are definitions of big people are waiting. There are laboratory tests, lipase, amylase, and of course there are other different crucial information regarding enzyme activity, regarding these trypsinogen 2, urinary amylase, which normally we don't do, but we do definitely an ultrasound. We do CT scan scoring in these cases, and we take the person in the in such a setting of the scoring of the severity. We take the patient either in the indoor facility, or we decide to do the ICU management. So we have scoring category to decide on which way the person is going. Is he going to the ward, or is he going to the ICU? And we start, of course, hydration as the first therapy, and then painkillers and other things. So, when you talk about approach, my approach would be very simple. Obese man, having this typical epigastric pain radiating to the back, almost there is no other DD. I mean, if you don't have a posterior duodenal ulcer, which is, good old days, which is to rupture, straight away, this is the format.
Yes. So I think that's what was done for this patient. So the doctors there in the ER sent all this investigation, which you just mentioned, which was rightly done. So the lipase turned out to be over 10,000, which confirms the diagnosis of acute pancreatitis. The total count was over 17,000. The hematocrit 46%, creatinine was on the higher side. And an ultrasound, transabdominal ultrasound, showed some peripancreatic edema. There was some grade 2 fatty liver, which is expected in this kind of obesity. The gallbladder was reported to have sludge, and there was partial contraction of the gallbladder without any wall edema. So now, when we have a diagnosis of acute pancreatitis, as Dr. Debash just said, the first thing is pain management, because that's the first stage for this patient. We will do all the other things like fluid and doing tests for looking at severity and trying to find an etiology. But the first stage is pain. The patient comes to us with pain, and that has to be handled first, right in the emergency. So now we have a whole gamut of pain medications, from non-steroidal anti-inflammatory, ketorolac, paracetamol, and up to low potency narcotics to high potency narcotics. So in your experience, Dr. Parimal, which analgesic do you prefer in your practice, and why?
So I think pain management is of paramount importance in patients with acute pancreatitis. There are two ways of going about it. One is you can use non-steroidal anti-inflammatory drugs, or you can use one of the opiates or their lookalikes in clinical practice. If you look at the chronic WHO pain pyramid, you start from a lower one and keep on adding. Here you need a top-down approach. So you hit hard with the one which is likely to give pain relief. Now in our center, our drug of choice is pentazocine. And we use pentazocine predominantly for these patients as the first drug of choice for control of pain. The other option is using diclofenac, and I think there have been some recent good trials on this which show that you can have similar results with both these drugs. There are upsides and downsides to each of them. With like opioids, one may feel that there can be sphincter of Fodai contraction, there can be ileus worsening, there can be drowsiness and certain problems which may hamper your treatment later on. But overall, if you look at the general recommendations in practice guidelines and our own experience, it is pretty safe medicine to give. Tramadol is a kind of similar medicine which is very popular in emergency departments. And very, very often we find that it's already given to a patient by the time the call comes to us. The other thing which is very commonly used is 1 gram paracetamol, which really speaking is not recommended in acute pancreatitis. At least to my knowledge, there's no controlled trial which has shown that it is effective. So top-down approach, use of one of the opiates as the first line. As a first line, you can use diclofenac, because at this stage, we would assume that generally the patient has come to you for the first time, not from some other facility, and there's no great risk of any renal failure. Then there are some patients who may not respond, and there are certain upcoming modalities like epidural anesthesia, which I have no experience with. And in fact, I was looking at the literature for epidural anesthesia, and this is of course later in the course, not for the first presentation here. There's a very recent EPAN trial which has shown that it is not really very beneficial, but I think it is an individual single trial. I would not know how many other members here in the panelists have experience with epidural anesthesia. But like I said, first opiates, possibly diclofenac, and yes, if he's not responding, fentanyl patch is a good idea.
Yes, I think that's perfect because Dr. Pramod Garg's group had shown in this elegant trial about pentazocine, which is a dual opioid blocker, so the adverse events are less and efficacy is more. But again, as you said, tramadol is very common and diclofenac both have equal efficacy, similar side effects. So based on your experience, but this fentanyl patch, epidural anesthesia, these are more of rescue medicines. If the above do not work, very rarely we use epidural anesthesia in our center, but mostly it is tramadol. But one thing one needs to keep in mind is always good to avoid high potency narcotics like nalbuphine and buprenorphine, because they as Dr. Lawate already said, they might be causing some kind of sphincter of OD dysfunction, which may increase the pain. And there is a large trial that we had conducted, observational study, multi-center, globally around more than 20-25 centers. And opiates have been, high potency opiates have been associated with adverse outcomes. So I think it's okay to go with tramadol or diclofenac and pentazocine. But only thing with diclofenac, we have to be careful about NSAIDs, the renal and the gastric side effects if they're being given very often. So now coming back to the patient, and this is, yeah.
Indomethacin, which we use commonly to prevent pancreatitis. You have any?
Yeah, that is post. Yeah, that is post CRCP. Yeah, that.
This would. Do you feel it?
Yes, we use indomethacin
in an acute pancreatitis pain.
Your voice is breaking, sir.
In acute pancreatitis pain.
In acute pancreatitis, yeah. Per se, we have not used it. We have used it. We use it routinely for this prevention of post CRCP pancreatitis, but we haven't tried per se in acute pancreatitis as of now. I mean, that's a good idea to begin or do some kind of a randomized control trial, actually. So conceptually, it should work, but we need to have the data. So this is how the case looked like. Now we have this patient of documented acute pancreatitis with an elevated TLC, increased heart rate, and increased hematocrit. So now this patient has to be admitted. So so this is an open question to all the panelists. So where would you want to admit this patient? In the ward or in the ICU or HDU? Anyone can pick up.
Sir, can I give?
Yes.
Anand, yeah, please go ahead.
Yeah, sir. Definitely, this patient is a pancreatitis, but still now there is no major organ failure. So it maybe there is a mild pancreatitis, which may subside normally. If only the TLC count little higher side and pancreatitis, because pancreatitis, this lipase numbers doesn't tell anything that higher number that is more severe or less severe. So maybe can be managed in the ward or maybe sort of SDU kind of system, but not require ICU care, these kind of patients.
Yes, this is very important because we should not be scared about the number of lipase. TLC in the first few days is a systemic inflammatory response. We'll come to that. So that also doesn't mean that the patient has an infection. And if we put this patient in the ICU, I think we'll be doing more harm than good by exposing to him a gamut of infection. So this is a very important point by Anand, that if the patient is not having any signs of organ failure at the time of presentation, I think a ward or a high dependency unit should be good enough. Now we have admitted the patient, and now it's important to look for the etiology. This particular patient told us about he took a binge drinking. He used to be a smoker, but that does not mean that smoking or binge drinking in his case is the cause. There could be other causes also. He's obese. He could have gallstones. So it's very important to look for the etiology. And here I'd like to invite Dr. Neeraj Jain to have your opinion on how you proceed to do an etiological workup. Dr. Jain.
Yeah. So, well, it was 3 a.m. when patient got admitted. Actually, the investigational workup for etiology may begin as early as early morning. And we have a very clear-cut history that this patient is an obese. He's a smoker. He is an alcohol user. He had a binge drinking last night. So far, we have a clue towards his etiology. That is number one, he can be an alcoholic pancreatitis. But nonetheless, he is an obese and he has some biliary sludge. So we need to have a very good ultrasound to prove that he has gallstones, and he has been a smoker, which is one of the etiological factors. He is an obese, so all lot of blood test has to be done to see for the metabolic causes of pancreatitis. The most important being hypertriglyceridemia, and his liver function test also should be done to see for elevation of SGOT, SGPT, which may give a clue regarding the biliary etiology of pancreatitis. He has to be asked history of drugs. He has to be asked about the history of biliary colics in the past. Obviously, serum calcium has to be done for hypercalcemia as a cause of it. And if you are unable to say reach to any conclusion, then we have whole lot of imaging available, right from ultrasound to an MRCP to an ultrasound EUS. Well, as far as CT is concerned, we would like to defer CT just for establishing etiology in the first 24 hours. We would try to defer CT.
Yes, exactly. And for the audience, I think a very important thing, usually we miss in taking the history in the emergency or maybe even the what is the history of drugs. We often take history of alcohol, smoking, but drugs we often miss, and many of these patients actually have. We that is very important. And one thing I have not listed here is the gliptins. Now there is a big noise that gliptins can cause pancreatitis, though it is controversial. There are papers in very high impact journal which negates it as a biological factor. It can actually, gliptins can bind to acinar cell because there are receptors in the acinar cell, GLP receptors. And when they bind, they can cause increase in secretion of amylase and lipase. So those hyperamylasemia and liposemia are not associated with pancreatitis. But a subgroup of these patients do have pancreatitis, but they also have obesity and the other risk factor of pancreatitis because of which gliptins are given. So it's very difficult to causal relationship of gliptins with pancreatitis, but if the patients are on gliptins, we have to be careful. So that history is very important, especially in today's context. Now let me ask Arun. So I have specifically mentioned what is the significance of evaluating LFT because again, this is a test which is often missed during the first workup. LFTs are done, and we see lots of prescriptions from all over the country, and many of you must have seen the same. If we see the reports on the day of pancreatitis, we don't see a LFT report. We see creatinine, we see TLC, we see DLC, the complete blood picture. So Arun, what as a surgeon, from a surgical perspective, why do you think LFT should be important as the first investigation in these patients?
From a surgical perspective, one is in gallstone diseases, we would see raised bilirubin, raised GGT, alphosphatase, alkaline phosphatase.
Yeah.
And from a severity perspective on admission, usually raised AST it predicts severity, Ransom scoring. And again, yellow or raised LFT may be because of different reasons also. It may not be only a gallstone, it could be a passed out CBD stone, or the pancreatic head edema also could be one of the causes.
Yes.
So
this is the, yeah. Yes. So this is how biliary pancreatitis happens. A stone will slip down, and is my mouse pointer working? Can you see my mouse pointer?
Yes, sir.
Yes.
Yeah. So this is how the stone would slip down and cause a transient obstruction. Usually it is transient. Most of the time in the ampulla, cause pancreatitis by increasing the pancreatic duct pressure, as Dr. Devashish told early on. And so when there is obstruction here, there will be a transient elevation of the enzymes that were supposed to come through the bile duct to the duodenum. And when this goes off, the obstruction goes off, then it comes down. So this is a very telltale sign, and it has been shown that with all the liver parameters, the SGPT or the ALT, if it is more than 2.5 elevated, more than 2.5 of the upper limit of normal within the first 48 hours, that is very important. So that is the window where LFTs has to be done. The first LFT needs to be done. So it has a specificity of 95%. So if this is present, then you are 100% sure, 95% sure that the patient has acute biliary pancreatitis. There may not be a stone in the gallbladder. A single stone might stop. So if this is there, you can outrightly make a diagnosis of acute pancreatitis, biliary acute pancreatitis.
In fact,
Yeah.
we were taught, I think we were taught that gallstones, if you have gallstone, then almost 85 to, I don't remember this percentage, 85 to 90% positive predictive value if your ALT is above 150 units. Obviously, and this should be done, of course, within the first 24 hours. So that was what, because we used to wait for ultrasound, person to come in the morning, so all that. But this biochemistry was done, and we used to say from that, I remember.
Yeah. So the point here is just mere presence of a stone in the gallbladder in a patient with acute pancreatitis does not mean necessarily it is the gallstone that is causing. So we have to rely on the biochemical parameter. That's very important. And then if the patient has an increase and reduction, biliary microlithiasis can cause, but during that first or second day is not the time to do endoscopic ultrasound. If there is a strong suspicion of biliary pancreatitis and we do not see a gallstone, but there is elevation of the HGPT, we can plan a EUS once the patient is stable. So again, EUS has the highest sensitivity to and specificity to detect microliths. Microliths are stones less than 3 millimeter, which is usually not seen on conventional transabdominal ultrasound or an MRCP. And the other issue is most of the time, many a time we see reports of biliary sludge and we try to link based on ultrasound and we try to link gallbladder sludge with acute pancreatitis. We all have sludge. Sludge is just mucin with bile crystals. If we see in a polarized microscopy, you can see pictures like this. So sludge easily passes out through the ampulla. We all have sludge. We fast for a few days, we get sludge. So, but within the sludge, there could be nidus and formation of microlith. Sludge never causes pancreatitis, but microlith can cause pancreatitis. So if we see a report of ultrasound as echogenic sludge, those are the sludge which may have microlith. And of course, if there is a stone more than 3 millimeter, it's easily visible. So we should not be or should be careful before jumping for a lap chole if we just see sludge in the gallbladder. So now, is it biliary or alcohol? That we will know if we do serial testing. So this is again very important. Testing, there can be three situations. One, initial improvement and then reduction. So it's improvement. So that has the highest specificity for gallstone disease. Static, it could be the patient had taken alcohol. So there could be a component of alcoholic hepatitis or alcohol-related liver injury. He had NASH. He could have NASH. Grade 2 fatty liver was there. So in that situation, the LFT may be static. And the other thing which may be worrisome is the worsening LFT. So here there could be two things. The most common scare that any endoscopist or any gastroenterologist here would have is a distal obstruction by a gallstone, which can cause cholangitis. And in this situation, it's the cholangitis then kill the patient rather than pancreatitis. And this is a situation if the patient has acute pancreatitis, gallstone, impaction in the distal CBD and cholangitis. This is an indication for an emergent ERCP and clearance of the common bile duct. But if there is no cholangitis, then it's better to wait for the acute inflammation to come down and then try to attempt ERCP to clear, because the ERCP itself can cause exacerbation of the pancreatitis or a second hit to the already injured pancreas. So this is very important. And the youngsters who have just started endotherapy, advanced endoscopy should understand this, that when not to do ERCP for biliary pancreatitis. So now the third, we had admitted the patient, as most of you agreed that this patient, the patient that we are dealing with, was admitted in the ward and then management was started. So now, again, I am coming back to Lawate, sir. Before discussing what we should do, what is the best practice, can you tell us, based on your vast experience, what need not be or what should not be done at this stage? Because you have seen, that lots of things which are not necessarily required is done. So we'd like to hear that from you, sir.
So actually, when you have a patient coming to you at this stage, things which you are not supposed to do, first thing is to not give antibiotics, very important. So I would say there are 4 or 5 antis which you should not give. One is antibiotics.
Yes.
Then the second was, at one time popular, was things like tracidol, that is anti-protease.
Yes.
It is not to be given. Then there were certain inflammatory drugs like lexipafant, which transiently seem to have been. So that is the third anti-inflammatory. So although we give these NSAIDs for pain, we are not sure whether some effect on the inflammatory aspect, but we don't give anti-inflammatory drugs with the aim of reducing inflammation in the pancreas. So anti-inflammatory, anti-protease, and antibiotics and all these antioxidants we should avoid at this stage. So that by way of the easy to remember antis. The second thing, probiotics have no role, and in fact, after that Lancet trial, they have shown to be dangerous, so we should not be giving. And by way of evaluation, I think a CT scan should not be done at this, the day one, and we should preferably do it somewhere around day 3, day 4, as per the indication. Unfortunately, what happens is a lot of people with pancreatitis who get admitted to our ICUs, nothing against physicians or the treating doctors, but from day one, they seem to be started on meropenem or piperacillin tazobactam, and it is completely wrong practice. I think if you are starting early antibiotics in a pancreatitis, it is only if there is a proven extra pancreatic infection which requires antibiotic treatment. I think is there
absolutely
overzealous IV fluid management. So that is also, which was at one time we used to write like 8 pints of whatever. That will be that part of further discussion in this.
Yes. So I think you are absolutely right. I 100% agree. So let us see why antibiotics should not be given. It's just an extension of Lawate sir's whatever he told. So this is again, I mean, I'm not going to scare you by talking about lots of molecular biology. So this is how the human pancreas look like, and this was the paper that we published like in 2017 and 20. And this is what, if you have heard about colopsin activation. So we won't stick here. So basically what happens when pancreatitis begins, be it biliary, be it alcohol, and we have shown this experimentally in human acinar cells, there is production of cytokines. And there will be a time-dependent increase in the cytokine in both biliary, alcohol, and even in hypertriglycerides and other etiology. So the acinar cell behaves like an immune cell. So this is the crux from this slide. The first response of the pancreatic acinar cell, besides getting activated by trypsin and destruction or apoptosis, it will start secreting cytokines, and this cytokine would lead to what we call systemic inflammatory response. Long story short, so this cytokine would result in activation of all these parameters, and this is what the patient presents to us because of the cytokine storm and cytokine response. There is no infection here, and therefore prophylactic antibiotic is not helpful. In fact, we may harm the patient by giving prophylactic antibiotic because once we start it, we don't know when to stop. And these patients, we have again done this study where we looked at the necrotic tissue for fungus. We did gene sequencing. And if you see, there is a whole gamut of fungus, many of them we haven't even heard of, that was growing within the necrotic collection. And there was loss of gut barrier permeability. So by giving overzealous antibiotic from early on and continuing it for a long time, I think we are not only not helping the patient, but also causing harm by causing fungal infection, which can add to the infection later on. So that is why it's very important to not give antibiotics for whatever reason in the first 1 week. So again, there is a rider. We'll come to that a little later about extrapancreatic infection. Now, once the patient comes to us, the first thing we look for presence of severe disease. Is the patient already having severe disease at the time of admission? And that can be done by something called modified Marshall scoring. If the patient do not have severe disease, then we have to look at the risk factor for severe disease. Is the patient going to develop a severe disease? Does he have any risk factor? And also we have to try to predict if we could predict the development of risk factor over the next 5 days, 7 days, 2 weeks. So again, now I come to Dr. Neeraj Jain. We just talked about the severity of the pancreatitis at presentation. So how do you define the severity of acute pancreatitis? How do we know that this patient is severe, this is not severe?
See, to define severity of pancreatitis, we have so many scoring systems, which are clinical, biochemical, radiological. But in clinical practice, we look at the parameters like pulse rate, BP, temperature, respiratory rate, oxygen saturation, LDH, And these are all criteria which define the severity of pancreatitis. Hematocrit is one of the very important parameters where we see the hematocrit values. If they are more than 45, we tend to push towards the severe grades of pancreatitis. So of all scoring system, Ranson system and Apache scoring system, they are all little cumbersome to do, but we go by all clinical criteria.
Yes, yes. So I think, yeah, if we talk about the scale, broad divided into mild acute pancreatitis, moderately severe, and severe based on the set. But actually, we are working on another revision of acute pancreatitis. It's a global group to more fine-tune the definition. So I will not go into this one, but suffice it to say 80% of patients have just mild acute pancreatitis who can be admitted to the ward and they go home by 7 to 10 days. And the rest 20 to 50% have moderately severe or severe. Severe means if the patient has organ failure which persists for more than 48 hours. And moderately severe has acute necrotizing pancreatitis, which is characterized by all these four type of collections and transient organ failure. And in fact, all of you must have experienced this kind of a patient who have a very fulminant, very severe disease, and patient succumb, patient die within days, or maybe within the first 14. So, had Pramod Garg from AIMS had coined this entity called fulminant acute pancreatitis, where organ failure happens within 72 hours, and subfulminant acute pancreatitis. Probably this would come into the new classification, we'll see. But then, Anand.
Yes, sir.
So let's skip aside our current patient for a while. So many of the patient would present as with at admission. They'll come to the ER and has already organ dysfunction. And especially in referral centers, this patient will come from other hospitals. They are referred with organ failure. So what would be your first line of management in this kind of patients who presents with organ dysfunction at admission?
First of all, sir, the most important criteria is there. The patient is coming directly to our hospital or referring from the other hospital. Because if they're directly coming to the hospital, we have a good scope for resuscitations or recovery. If patient is coming from the referral center, definitely we have some time we already lapsed. So we'll talk about the patients is coming with the organ failure. So mainly the 3 or 4 organ which are most important, which is mainly affect to the patient of pancreatitis. Most common is the renal. The KKI, basically we know that is a volume depletion state. So the kidney injury is the most important. If someone already has received the CECT, because that is a contrast induced, that may worsen the renal failure. The kidney, definitely fluid resuscitation is the important. Yeah, we know there is a moderate fluid resuscitation is the most important criteria. Our main target is to the urine output. If patient is maintaining urine output, that is the only criteria, just maintain. And we have a proper guideline for that now, that moderate fluid resuscitation, we can give 10 ml per kg per hour, per kg as a bolus, then 1.5 ml per kg per hour to maintain the urine output. Another important organ is the lung. If patient is a mild or moderate, if PF ratio, we will do the ABG, PF ratio is less than 300, it's called the mild ARDS, because they may be the extra secondary ARDS because of the pancreatitis, is the haziness in the shadows, so that can be managed with the nasal prongs. But patient is the severe ARDS, definitely may require ventilation. NIV should be avoided because this patient already is a gastric bowel dilatation, ileus is there, and then NIV may cause the aerophagia. Most of the ICU setting they put on the NIV patients because those are the middle of the patient. Better go with the HFNC. HFNC will give the better and the almost same effect. If not maintaining the intubation and the lung protective ventilations, go with the 6 to 8 ml per kg total volume with the ideal body weight is the good. Another important organ failure is the cardiac. The maintain the map. If not able to maintain the map with the fluid, better to start the vasopressor. Now recent study come in the sepsis also. They are saying don't give more fluid, give the vasopressors, maintain the map. You may require a less fluid, so you can avoid the fluid related complications. Fourth and the most important, which are mostly avoided, is the gut. Gut is the major organ which mostly avoid. Don't keep patient NPO. If patient is tolerating feed, please start the feed. These are the 4 most common organs which need to be addressed. The second question you are asking, what precaution would you take if the patient has other major comorbidities? This is a very challenging for us because if patient is a CLD, a patient is a CKD, patient is a CAD, we have a restriction for the fluid and we can't give more fluid. If the patient already, these are the tachycardic, hypertensive, cardiac patients may compromise. These patients are really challenging to manage, but we need to manage with to not exaggerate the prior existing conditions because these conditions may worsen the outcomes.
I think it's very important, and points on use of NIV and fluid restrictive approach. Give more of vasopressor rather than pump them with fluid. These are very important. Those are also the precaution that you are taking if the patient has a background cardiac comorbidity or a chronic renal failure. So I think this is very important message for all the physicians and the intensivists who attending to this talk. So now again, I come back to Dr. Debashish Basu. Do you think this patient has a risk of developing severe disease because his biochemical parameters did not indicate organ dysfunction at the presentation?
No.
But is he likely to have severe disease?
Yeah, in fact, if you go by, just the biochemical parameters looks, fair enough. The obesity is the worrying part and associated, the gallbladder study, etc. But if we revisit the Ranson criteria, I think a good friend, he already said that these are the things that we have in, have a big list. But if you're actually working on this kind of a setting, I think we need to again revisit the criteria about those 11 parameters, whether you're really thinking about an alcoholic pancreatitis. So those 5 criteria, which was there for the admission, and those, after 48 hours, now the things, your calcium level is going down, your hematocrit is also falling by 10%, your PaO2 less than 60. So these are, the bun. The bun is a very important factor, despite the IV hydration, the base deficit of that 4 milliequivalent per liter. So these are the things that we need to keep in mind. The modified Ranson criteria talks about the Gallstone pancreatitis. So we need to assess the patient also on these criteria. So whether the age is, but he is young. So we go by his WBC count, his glucose values, etc. So I think on view of that, and clinically, if you go, now today you have a thing called BISAP score. So that's the that's a bedside score. So which gives us also a clear indication of where we are heading towards. And I think as clinician, as a doctor of medicine, I would say that the bedside index, for severity in acute pancreatitis, it is a very important tool that helps us predict the severity of acute pancreatitis. Which is my next question, is that I would say the intra-hospital mortality is also, there's a algorithm on the computer. You go on the internet access and you put the values and you get a measure of it. So you get a score.
Yeah. So yeah, correct. So basically, the whole disease is complex, and with evolving knowledge, I think rather than getting more relatable answer, if we go through the literature, we are getting more and more confused. So currently, only 3 things can be considered as a risk factor. That's a risk factor of any disease, morbidity, and obesity. And obesity was the risk factor in our patient. Why obesity is an independent risk factor? Because the fluid dynamics in an obese person is much different from a lean person. Obese person would have total body water in severe obesity is like 40% compared to 70% in non-obese. So these patients require a little bit of higher fluids.
So
and on that, there will be adipocytokines.
Yeah, the sequestration of fluids, if it is more than 6 liters. So that is also criteria.
The volume of distribution, they will be requiring more. So that is why obesity has to be seriously looked at as an important independent risk factor. And then, so this is a cartoon again. This is a necrotic pancreasol, peripancreatic fat, and these also obesity. It's always in a pro-inflammatory state. And then with the necrosis, there will be secretion of all these adipocytokines, resistance, risphatin. So this contributes to the cytokine storm, and that's why these patients are more severe. And Anand has to work harder in this kind of a patient when they are in the ICU. Now we know about, we just talked about Apache, Ranson's, BICAP. So there are several multimodality and single parameter modality to predict the severity. So Dr. Lawate, which of the severity prediction tool do you use in your practice? I mean, again, you have seen the different offshoots of disease.
So this is a very important question because of two reasons. We use these severities prediction tools for two reasons, I think. One is to triage these patients. So you do the scoring and you know that this patient is predicted severe acute pancreatitis and you decide where you want to admit him. And the second thing also is preparedness. So if you know that this is predicted severe acute pancreatitis, you can take adequate precautions by way of hydration and what all has been discussed. In very simple terms, I would put them into two groups. One is wisdom based. So a lot of people who have been practicing like 20 years, 30 years, we can look at a pancreatitis and say that this patient is likely to be not doing well. But I think leaving aside that, my choice is actually to, for our casualty doctors, I tell them do the HAP score. And for our ward doctors and gastro colleagues, I tell them to do the BICAP score. Because these two I find are reasonably easy to do, and you can use them very easily and practically, and there's no complication in it. So, like if you look at the BICAP score, you have 1 point each, and as the number of points increases, there's increased risk of developing all these problems, mortality. So, with time, I think a lot of our residents also have started using this in clinical, and they write it paper.
Yes. Yes. So actually, we had published a paper on HAPS. HAPS seems to be a good marker in the emergency setting because it can tell you which patient will go on to develop mild disease. All the other parameters will tell you about prediction of severe disease, but HAPS does the other way around. But this was a very nice study published in 2012 in gastroenterology. What they did head-to-head comparison of all the existing severity score, Apache, BICAP, Glasgow, HAPS, Japanese system, PANC3, Ranson, SIRS. And what they found is a very big number with a good validation cohort, and all the scoring systems had comparable performance, but only with moderate sensitivity and AUC. So none of them were better than the other. The specificity was not very high to definitively tell that this patient is definitely going to have severe, and that is what we see in our clinical practice. We think this patient, okay, the CRP is so high or the BICAP is 4, but many of them do not end up in the ICU. So what we do at AIG, and I think many pancreatology centers have started following that, is we look at only the systemic inflammatory response, because I've shown you a cartoon how the acinar cells can produce cytokines and then systemic inflammatory response.
Yes.
So this has a direct relationship with the pathophysiology of the disease. Based on the severity of the acinar injury, there will be more systemic inflammation. And that is why, and it has been shown in studies that if the SIRS is persistent for more than 72 hours, or if there is a progressive increase in the SIRS, deterioration of the SIRS, those are the red flags. Those are the patients which are likely to end up. So this is a very simple test. It can be reproduced. It's reproducible. You can do 100 times in a day. You don't need any expertise. It's non-expensive. It's mostly clinical based, except for the TLC that can be done in the wards.
My dear Rup, I mean, is it 72 hours? Or, I mean, this is exactly what I was waiting for in our routine practice of teaching. We say 48 hours. I don't know. Now I have to correct myself. And this is the most, universally
no, 48 to 72 hours. Yes.
So it's 72.
So,
I thought
this is 48 to 72 hours. There's a window. But beyond 48, you have to be aware. You have to be aware. So this is the simplest, and that can be done. So this is and we find this to be useful in our day-to-day clinical practice. BICAP is good, but again, it has standard. Even though it has 5, the individual components again have subcomponents. So at our center, we follow this SIRS score, which we find to be useful. Now treatment starts, and now this is the
this program. This is the most universal, I think, the way all can accept rural, semi-urban, urban, wherever you are. Yes.
Exactly. Yeah. It can be done in any level of healthcare You don't need to have specialized infrastructure. Yeah. So now let's come back to the therapy for this particular patient. And this patient did not have a severe disease, and his SIR score was 2 or 3 when we looked in a daily manner. So Anand, what would be your principles of fluid therapy? We have been talking about fluid therapy. It is a big buzz. It has been a big buzz for over last 20 years without coming into any consensus. So what would be your take on fluid therapy in this particular patient? He's obese. His renal functions at this point are normal, but he has a risk factor for obesity. He has SIRS, which will be persisting. So how do you treat this particular patient with fluids?
Sir, I'm in a 15-year critical care. Mostly I'm doing in a gastro only. I have seen the era when the used to give a rush of the volume like a 3 or 4 liter in a 1 or 2 hour. Now we are realizing that because in a critical care, the good thing is that we have an ultrasound. The ultrasound is the very important tool because it's a very reproducible multiple times. So if patient is just assess the volume status, first is the volume is a hypovolumic, isovolumic, is a normovolumic, or is a hypervolumic. If patient volume status is hypovolumic, give the moderate in the resuscitation with moderate fluid, and that may be crystalloid only. No role of colloid, no role of albumic. Crystal is the fluid of choice. And then if the reproducible, you can see your target will be the urine output, SIRS response. If SIRS response is responding, that mean to say that my patient is responding, lactate level is down. The PLAPS, there's a posterior lateral alveolar pleural syndrome. PLAPS is the points. On the lung ultrasound, we can see all the 8 points are there. If there's a no B line, mean to say you can give the fluid till then B lines is not appearing. This patient is the urine output is good, creatinine low. This patient is obese. The problem with the obesity patient is the volume, intravascular volume is less actually. So they may require more volume as compared to the other patients. So if patient is a hypovolumic, as you are showing, is the 10 ml per kg, give 1.5 ml per kg per hour. Urine output is the only thing. If urine output is maintaining with the low volume, better to go with the low volume. Don't over resuscitate. Don't over resuscitate the patient because the lung issue will complicate in later parts. So the urine output, lactate, ultrasound, IVC diameters, SIRS response, these are the things where you can titrate. If lungs are getting wet, B lines are appearing, this is the time where you need to stop your fluid resuscitation.
Yes. Yeah, I think, and the other important thing that I think I had, so the checkpoints, it's not that we just see the fluid at one and then it has to be very frequent checkpoints. And based on, as Anand has already said, based on the volume status, we may either increase or even reduce the volume if we see the risk of overload, or if there is overload based on B lines and SIRS response or urine output. And the most important thing to understand here is beyond 72 hours, fluid therapy has no role. Whatever damage has to happen in the microvasculature will happen in the first 72 hours. And fluid therapy can help only in the first 72 hours. Beyond 72 hours, if we give aggressive fluid, that actually would more harm to the patient than good, as Anand had mentioned. Again, Anand already said it's moderate therapy, and it can be either normal saline or ringer lactate. There was a trial that showed ringer lactate is somewhat better, and now also the general consensus is ringer lactate is the first choice. But then a good randomized control trial is underway, led by a Spanish group which is comparing head-to-head normal saline versus ringer lactate. So maybe sometime mid of next year, we should get the results of this, and that would give the answer which is better, actually, normal saline or ringer lactate, or both.
As even though, sir,
Anand,
in a clinical practice, sir, normal saline is not a very good crystalloid resuscitation as the large volume because it may worsen the acidosis part. So hyperchloremic acidosis is one of the another complication which may worsen the outcome. So ringer lactate or the plasmolite, these are both are the best crystalloid for resuscitation, sir.
Yeah, so they are more physiological in their content. You're correct. I mean that avoid the acidosis part can be ameliorated. Okay, now so this is again a big controversy. So how to feed this patient? So many people follow start diet once the pain is resolved, or many clinicians would wait for the bowel sound to return or the patient to pass some flatus. or once the patient tolerates, or whether the patient should have a desire to eat. So I think here, Ruchir, you have to chip in. And so how do you feed this patient? When did you start, and what would be your diet plan to give him adequate calories?
At the outset, I would like to thank Rupjyoti sir and all the other doctors here for giving me an opportunity to be part of this symposium. Regarding this patient, when to start his diet, the patient appears to be an obese patient who's developed severe pancreatitis, severe acute pancreatitis. So earlier there was a concept of withholding diet for the first 20, keeping the diet nil per patient, nil per orally for a day, which is no longer the case. Recent evidence shows that starting food within 24 hours shows a good outcome for the patient. And the gut dysbiosis or bacterial translocation which could have happened if the patient is kept nil per orally is prevented if you start the diet as soon as possible. Regarding the diet, from a nutritional point, you can approach it in three basic ways. When to start the diet, what do you start in the diet, and how to give the diet. So regarding when to start, like I said, the concept of giving the bowel rest, like the slide shows, is no longer considered current practice. It's better to start as soon as possible on day one. Regarding what to give, if oral diet is considered the better alternative and most preferred, if the patient can tolerate an oral feed, it's always preferred. If he can tolerate food, it's a low-fat, solid diet that should be started at the earliest. And if not, enteral nutrition can be started. Enteral nutrition can be either polymeric or semi-elemental. Both of them have shown to be similar efficacy according to the ESPEN guidelines. But usually a combination is given. And regarding how to give this diet to the patient, either a nasogastric or nasojejunal tube if the oral feeding is not tolerated well. Both of them also have been shown to be equally effective. So the choice of whether to give nasogastric or nasojejunal is left to the treating physician usually.
And Ruchir, can you just explain to the audience, so what is the difference between, or what is a semi-elemental or a polymeric diet? I mean, we always hear these terms from the nutritionists, but we really don't understand what's the content and how much calorie they provide. So, am I audible?
You are audible, sir. I think Dr. Ruchir is facing some network problem.
Okay. So anyway, that's not an issue. Yeah, you heard? Okay. Okay. Yeah.
Yeah, he is online now.
Yeah, Ruchir.
Yeah. So the semi-elemental the semi-elemental formulas are actually broken down into individual peptides, making them easier to digest. So earlier it was practiced to give semi-elemental feeds to pancreatitis patients, but both polymeric and semi-elemental have been shown to be equally effective.
Okay. So before we go at the case, this question to the organizers, Pradipta and the others. So just tell us when to stop, because it's already going to be 1 hour. So because there are other issues that we can decide to stop, can do that, right? So
we can continue and complete this, sir. No issue.
Okay. So then. Okay. No problem. If it's okay with
you can
make
continue.
one statement. There's this ESPEN guideline on clinical nutrition in both acute and chronic pancreatitis. I think this is a must read for all of us. Not only a person who is specialized in nutrition, This is a very
Yeah.
clear, example that they have given. A very good commentary. I think we must all read this. S-Pen.
Yes.
Yeah.
Yeah. So let's go back to Mr. He, our young, happy-go-lucky person with acute pancreatitis. So this is day 8 now. He continues to have pain, but now some new events have developed. From day 6, he had started developing urine fever spikes. There was a gradual reduction in the urine output, heart rate increased, BP started falling, TLC increased. So, Dr. Basu, what's going on here?
Well, I mean, if his condition was otherwise stable and suddenly this is showing up, we can say that there is an early intervention of an infection coming in, from somewhere, maybe from pancreas, maybe from extrapancreatic source. So we must, delve into that. So we see that the heart rate is high now. The BP is, getting lower. The TLC has gone up to 25,000. So this is where we are. And we must do a few, investigations, at least now do a good CT scan to find out whether there's, a pancreatic involvement there in terms of complications, or maybe or some, and do a urine culture, complete urine examination. So these are the things that we'll do. What steps you will take. But this is all because we, as you said, that we don't like antibiotics in the first 7 days and all that. So these were initially very contradictory points to talk about. But now we have all, consensus is that we have realized that prophylactic use of antibiotics to prevent secondary pancreatitis, it is very controversial, and we will not do it. And pancreatic infections like peripancreatic infection is something to be ruled out at this moment. If the patient is in the hospital for 6-7 days, there are other issues in, maybe septicemia, maybe respiratory tract infections, maybe UTI, local abdominal cavity infections.
Yes.
These are all to be kind of thought of.
Exactly. Yes. This was the time where a CT is required, as you rightly said. Done in these patients, and that's pancreatic and extrapancreatic necrosis with ill-defined peripancreatic collection extending to the left colic duct, if you see in this CT scan. And here the whole pancreas is necrosed in the upper panel. And this is what, so now the question is, usually infected process is occur from second week onwards, towards the later part of second week. And patients are having fever day 6. So it's too early to have infected necrosis, even though it's possible. And that is why it's very important to think of pancreatic infection, which is not uncommon. A series of
I'm not able to
studies
see
from,
slides, sir.
Something.
Slide we're not able to see, sir. Other people can see, sir?
I think
No, sir.
sir has disconnected
I think
again.
Let me share again.
yes, sir.
Can you see now? Yeah, okay. So
We cannot see you, sir. Your video is, I think.
So this was okay, but it's okay. Slide, I think that's more important. Okay, can you see the slides now?
No, sir.
No.
No, sir. No, sir.
Can you see the slides?
We can't see the slide, sir.
Oh, you are not seeing the slides?
No, sir.
No, sir. Ah,
We are also not seeing you.
we
see
can.
you now.
Yeah. Your video we can see now, but slides.
okay.
So I think, Rup, we can read out exactly what we found in
I'll
CT scan.
stop sharing. Yeah. So reshare now.
No, sir.
Slides are visible now.
No, sir.
No, sir.
Okay. Anyway, let me read out. So you can hear me, right?
Yes, sir.
Yes,
Yes,
sir.
sir. Yeah.
I'm audible, right?
Yes,
Yes,
sir. Yes, sir.
Yes, sir.
Okay. So the CT showed there was pancreatic and extrapancreatic necrosis with ill-defined peripancreatic collection that extended down to the left paracolic region. And we also the chest left lower zone opacities. The importance here is the patient. We usually expect infected necrosis from the mid or later part of second week. But here the fever started from day 6. So this is important. So this was again alluded to by Dr. Debashis earlier to look for extrapancreatic infection. See now?
Yes, sir.
Yes, yes.
Slides are visible?
Yes,
Yes,
sir.
yes.
Slides are visible.
Yes, sir.
Okay, so it's important. Okay, great. So it's very important to look for extrapancreatic infection if the fever and other changes begin early on. And these are some studies from our group, and similar studies have been published from the West. So even patients with mild acute pancreatitis can have pneumonia, UTI, and sepsis. And of course, other category of patients will also have this infection. So it's very important to realize that there is a common habit in many centers to put in a catheter. That the ER, if the patient is saying not passing urine or any critical care is put in a catheter, that should not never be done, because that can be a cause of UTI and that can contribute to the morbidity of the patient, right? And if the patient has a extrapancreatic infection, it has to be treated as such. So not all infections in AP are necessarily infected pancreatic necrosis, and this thing is important to be understood, because that would help you make a right use of the antibiotics. All patients do not need meropenem in the first week. If it's a patient, you can go with a different lower grade antibiotics. So we can skip these studies. So basically, patient has interstitial edematous pancreatitis, no prophylactic antibiotic. And if you document extrapancreatic infection, then infection specific to that infection, extrapancreatic infection has patients who has acute necrotizing pancreatitis, again, no prophylactic antibiotic in the first week. But from second week onward, the patient has clinical deterioration, rise in TLC, persistent SIRS, and if you do a CT scan that shows air bubbles, these are the patients where empirical antibiotic has to be started. This is not prophylactic antibiotic. This is empirical. We know that there is an infection, but we don't have the culture sensitivity report, so we start an antibiotic. What antibiotic? Antibiotic that penetrates the pancreas. And that can be regulated by doing procalcitonin. Again, there was a nice study from Manchester where procalcitonin can be followed if it is more than one antibiotic can started or upgraded. And if the calcitonin is less than one, you can downgrade or even stop the antibiotic, because that has been shown to be associated with the infection. So this is an important paper. And the antibiotic has to be, if we are thinking of infected necrosis, something that penetrates the pancreas. Imipenem is the best choice. Meropenem may not be as good as imipenem, but in clinical practice, again, meropenem is used more. But there are ample evidence that imipenem is the best. And others that penetrate the necrotic pancreas include ofloxacin, metronidazole, cefoperazone. So it should be between these choices. Now again, let's go. So this is the patient now we have who have infected necrosis, who has organ dysfunction and impending organ failure. So will you take over the patient at this stage, Anand?
Sure, sir. This patient is fitting the criteria of the ICU, sir, because we know that tachycardic, tachypnea is there, abdominal distension, sepsis is there, and borderline BP, consistent fever, decreasing urine output. Definitely the organ failure sometimes is setting the organ failure. So this is the stage where we are suspecting either the pancreatic, extrapancreatic sepsis is going on. Maybe the hospital-associated infections like, as you said, pneumonia or UTI. These are the source of the infections, these are the things which we are giving for the patient from the hospital. So we need to avoid as much as we can possible. And already this is the first week already gone. This is the second week. Definitely we need to start the antibiotic here. It's a broad spectrum antibiotic because borderline BP and tachycardia. Definitely Penem will be the first choice in these kind of patients, not less than Penem, because we always have a chance to downgrade. Always hit hard, hit fast. This is the principle. If after 2 days, 3 days patient response and we send the cultures or something is not growing, definitely there is a chance for downgradation. But initially, definitely Penem is the choice. Imipenem, meropenem, both are the good. But yeah, imipenem intra-abdominal biliary penetration studies say that's good. So imipenem is the better choice in this one. Along with that, we need to send a culture, and if possible, if there's a left paracolic gutter collections are there, if it is a liquidified, definitely place the drain and send for the culture so we can see the better which bacteria is going, what is the sensitivity. Source control, we can start thinking, but this is a very early stage to say that we can do something at the age of the time of the day 8. Yeah, it may take around 2 weeks or 3 weeks. That is the best time to do any source controlling. But intra drainage or the FNAC for the that area we can do it for the growing the infections. What infection is growing, sir?
Yes. So FNA,
this
there
is
are studies. So FNA is not usually practiced now. I mean, but of
yes,
course
sir.
you are right. Starting of source control at this point, day 8 may not be the right one. But again, the norm or the common thinking is like delay any kind of intervention beyond 4 weeks so that the wall is formed and the collections are more organized. But now there are studies for very select patients who are rapidly deteriorating in their clinical condition, obese patients like this, we might have to go in at least with a drain, maybe as you rightly said, 2 weeks or 3 weeks. But it has to be very selective based on multidisciplinary discussion. And yeah, so we can offer a very select group of patients some kind of intervention early on within the first 4 weeks, maybe at 3 weeks or so. And the other thing is, we all know here, all the panelists should know what is done within the first few days, first 5 days, 7 days may determine what will happen to the patient in the later stage. And many a times when we see the patient come to the tertiary care centers, they are already in a persistent surge state or impending organ failure, or may be already overt organ failure. So again, this Anand can answer, or anyone can take up this question. How proactive should be the doctors in the primary centers be to transfer the patient if the hospital do not have an ICU facility? Should the patient be held on to that hospital for a long time, or they should send off early onto more advanced centers with ICU facility?
So the most important thing, the diagnosis of pancreatitis, if the person qualified is difficult to make, because if the pain and ultrasound or the lipase is enough to make a diagnosis. Secondly, the most common investigation is hematocrit, which can assess the severity, which can tell the predictor. Each smallest hospital had a hematocrit. Bicep score, you can predict the severity more than two. Not require many investigation, not require ABG also. If you know that it is a severe pancreatitis, better to move this patient to where they have a facilities. The most worst thing in this, what we are seeing in our tertiary center, they are already done on the day 1 is a CECT. That is really is alarming, and still after so much awareness, still the people are doing CECT. That is complicating patient, as you rightly said. The first 48 to 78 hours, what you will do, definitely patient will be here for the next 4 weeks. And it may worsen organ failure also and worsen the complications also.
Yes, I think all the other panelists agrees to this. Yeah. Okay, so early transfer is very important if the facilities are not there.
Even from a medical legal standpoint, I think if you don't have a ICU facility, if the patient is deteriorating, we don't have any business keeping the patient with us.
Right. So again, so persistent organ failure is the single most important determinant of mortality. I'll not go through this literature, but so that we have already realized. So now we have this patient who has impending, or in fact, he has already organ failure has evolved, and will keep him in the ICU now. So this patient also has some abdominal distension, low urine output. So is some kind of abdominal compartment syndrome going on? So Dr. Lawate, can you enlighten us with this entity and how do you approach?
Yeah, so in simple terms, abdominal compartment syndrome is a syndrome where the intra-abdominal pressure keeps on increasing. It splints your diaphragm, and then it causes a lot of downhill courses in various organs. As gastroenterologists, many times we tend to think in terms of only the GI organs, which are affected by the abdominal compartment syndrome. But we have to remember that a lot of other organs, like you can have the renal vein which gets compressed, you can have the diaphragm which is splintered. That is why you can have effects on the cardiac and so on. So there are a lot of extra abdominal organs which are also involved. The diagnosis is theoretically, if you want to make a correct diagnosis, you have to have a urinary catheter you put in the transducer, and then you put about 25 ml of whatever normal saline, and then you measure the pressure. And if it is, say, more than 20, and if there's organ failure, then you can term it as acute abdominal compartment syndrome. Pancreatitis is one of the commonest causes for this. And leaving aside this, I think clinically also, if you have a person who is having gross distension and ileus, decreasing urine output, and going into organ failure, you can think very strongly in terms of acute abdominal compartment syndrome. I don't know how many of panelists here
So will you
think the urinary pressure transducer measurements, or whether at AIG you are using it or
Anand, you can answer this. I mean,
Sir, yes, sir. This is the intra-abdominal pressure. Urinary catheter is the one of the best methods that we are using here. And it really reflect almost the whatever the intra-abdominal pressure is more than 20. Definitely, we are looking like the highest pressure is higher side. With organ failure, definitely is alarming for us, sir.
so.
and
One
yeah.
of the challenging things to manage in pancreatitis, because there you start getting restrictions on fluid, you start getting restrictions on feeding, you start getting the bacterial translocation, the patient rapidly goes into sepsis. Many times this patient is just about in the second phase, the things have not really liquefied, and you can't do anything much by way of interventions. So I think it's the most challenging phase of acute pancreatitis to manage. If you look at grading and all, we won't go into it. But anything where you have this clinical picture and you have this pressure which is more than 20, you should definitely think of abdominal compartment. There are various treatments for it. Basically, one thing which we do actually in clinical practice is to try and paralyze the patient and put him on a ventilator, because that kind of relaxes the abdominal wall musculature, and you get little more space rather than having a compressed abdominal wall. The second thing we do is we can try some feeds, nasojejunal feeds, but they generally don't work. We have to avoid overzealous fluid management in these patients. And if there's ascites, we can tap it. So there's not really very great things which you can do. But basically, you try to relax, you try to remove things from the abdomen, and try to see how you can reduce the abdominal pressure. You have to also take care of intensivists and see how you can maintain the other organs, because like I said, many times the pressure is not so high to obstruct the arterial flow, but a lot of venous impairment can occur. So if the renal veins kind of gets compressed, you can have downhill effects on the kidney and urine output and so on.
And any surgical intervention? Arun, do you have any surgical intervention? This kind of patient.
So this would be a very scary situation. We would not like to intervene very early in these cases. As Dr. Lavate said, we would try and exhaust all other options first, like drainage and NIV, paralyzing the patient. If nothing works, then we can have a option of a laparostomy at the end. So where we open the abdomen and use a Euro bag or a Bagota bag to just cover it temporarily, see how the patient does. But that would be a very bad state for the patient.
Okay, so coming back to our patient, Anand, you wanted to say something?
Sir, sometimes neostigmine may be helpful actually, sometimes.
Okay.
If bowel obstruction is not there, then neostigmine may be helpful, sir.
Agree. We use it in our clinical practice, definitely.
Okay, so we'll go fast. I mean, now Ruchir, again, back to you. So would your approach for this patient now in the ICU and having possible abdominal compartment syndrome, we don't know the pressures, will your nutritional plan at this stage change, or it will be same for any other patients?
So currently for this patient at this stage, it's unlikely that he will be able to tolerate oral feeding. If he can, well and good, we can go ahead with the oral feed. If not, parenteral nutrition would be the preferred route. Most likely he would have a central line in place by now, so we would give him parenteral nutrition through the central line. Regarding adequate calories, it depends on the formula. The formula dose can be adjusted for his caloric needs. And
Okay.
we would always try to ensure that we revert back to oral feeding as soon as possible. So like
Okay.
Dr. Devashish said, the ESPN guidelines are the best source for info regarding these patients.
Yeah. Okay. So Anant, would you like to put a central line in this patient?
Sir, may require, sir. Because this patient already in a sepsis part, maybe, and the feeding is not possible. So as Dr. Rashid already saying, we require the TPN, not for the especially TPN, but for the better monitoring, we can require, sir. But as much as we can avoid, sir, as much as we need to avoid, sir.
Yeah. So that should be the message. Like, I mean, the threshold for using a central line should be very high when all other options are, because we should not send the message that central line can be used for any kind of patients in the ICU with AP, right? Because it also has its own flip side in monitoring the patient in the measurement of the pressures and things like that, right?
Is
So
there,
yes, of course.
Is there any role for
we have
nutrition in these patients? Immunonutrition.
Ruchir can answer this question maybe. Yeah.
For immunonutrition, glutamine has shown to have a role. Some trials have shown that glutamine helps in patient outcomes, but other than glutamine, other immunonutrition like amino acids, not that much. But glutamine, I would definitely think of at 0.2 grams per kg.
Yeah. So there was a study from our center also, like glutamine.
Immunonutrition has been actually shown to reduce mortality. You know, that is a very important component why we talk about immunonutrition today in this kind of setting. I mean, where we are trying to combat the effects of enteral, parenteral immunonutrition, it actually reduces the mortality. The hazard ratio is pretty good. And of course, the infection, other infectious complications also, the length of hospital stay, they all change.
Yes.
Than standard nutrition.
Yeah. Anand, you were saying something before we go to the next.
Yes. So I just want to say, if these kind of patients, there's a three kind. One is a central line, one is a cannula. There's a middle of that, it's called the midline. If you have a facility, use the midline, because midline will solve the purpose of central line also. Those not require central line and can avoid the infection also, because it is a 11 centimeter. Most of the people generally don't put because require little expertise. So if your intensivist are a good expert, definitely go with the midline is better solution.
Okay. Okay. Yeah, that was a good point. I mean, yeah. So, okay. So day 15, the patient continues to have fever. There was no change in the vitals, and now he's requiring increasing dose of vasopressors. Arun, so should we consider now he's into second week? So any kind of drainage? If you think yes, what would be your choice of route of choice at this point?
So usually the first choice would be a percutaneous drainage. Whatever non-surgical can be done would be the first option. So we might consider repeating the imaging at this point. The last one was done at day 18 and is still working to see what's happening inside.
Yeah. But now what happened to the patient is conservative treatment was given. Somehow drain was not put. And then on day 21, he continues to have fever spikes, low urine output, and his source was deteriorating organ failure was worsening, counts were high, severe metabolic acidosis. A CT screening was done here. Contrast was not used in view of the increased creatinine. And this is what was seen on CT. Huge necrotic collection with a large air bubbles within the collection. So, Dr. Neeraj, to do at this point? Infected necrosis,
Sir, Dr. Neeraj Jain,
sepsis, large air bubbles in the collection. Okay.
Sir, Dr. Neeraj Jain
no
is
problem.
not
So maybe
available.
Dr. Lawate can take this up. Okay, no problem. Dr. Lawate can take this up, maybe.
Can you just show
what would be your next investigation of choice at this point?
Can you show the CT?
Yeah. So he's good.
Yeah. So
this one. Can you see?
Yeah, you can see two things as far as I can see. One is there is air in the pancreatic collection, and there's a hugely dilated colon. So two possibilities we have to keep in mind. One is gas-forming organisms which are causing an infection, and second, there is small chance that there could be a colonic perforation related to acute pancreatitis. That's almost like I would say fatal complication in patients. But they are not in any condition to be taken up for surgery or whatever.
Right. So at this point, what we did was a CT cologram, and this is what came out. So if you see, the contrast was trickling down into the collection, which confirmed the presence of a colonic communication. Yeah. So now again, Arun has to save the patient. So how do you approach this situation at this point?
Yeah. So
Like
first
third week
must
of
take the
disease, colonic
patient
perforation, sepsis, organ failure.
So in this case, we will need to divert the bowel. So after taking all grave risk consent, take the patient up for surgery, see which bowel comes up for a diversion, and if possible, drain the collection intra. Keep fingers crossed. Most of the time, we may not be able to close the abdomen also in this. I expect a lot of complications in this patient, like bleeding, burst abdomen, stoma retractions, and prolonged ventilation ICU stay.
Would you
endoscope
consider a vacuum abdominal, open abdomen in these patients?
We could leave an open abdomen, sir, and just cover it with a maybe not a vacuum immediately because the bowel would be exposed. With what we usually do is take a sterile Euro bag and tie it to the rectus sheath and leave it. The technical thing that is available is the Bogota bag. I don't know whether it's available everywhere. So usually whenever we have done it with the Euro bag.
Okay, so so let's quickly come back to the case. So he underwent a very bad course, but eventually he survived with all this surgery, and we could discharge him after 38 days. And so I think so this brings this completes his first 4 weeks. So I was thinking, since we have a expert physician and diabetologist, to look at a little bit of into the follow-up and complication, but I'm afraid we don't have that much of time. We're already 1 hour 30 minutes. So I think we'll stop here, and maybe the long-term complication of exocrine, interesting studies and interesting discussions were there, where I would have loved Ruchir speak and Dr. Debashi speak of the exocrine, but I don't think we'll have enough time now. So maybe we can defer this for another webinar. I mean, the organizers can think of that, Pradipta. So I think we'll stop here with this take-home message, which should not be done. There is no evidence of benefit of Riles tube aspiration, as Dr. Lawate in the early part told, anti-secretory agents, protease inhibitors, immunonutrition, except for some mid-level, medium-powered studies for glutamine, prokinetics, antioxidants. These have no evidence of benefit, so should not be used. Glutamine in select cases maybe yes, and few of the things may actually cause harm. Aggressive fluid therapy, folic catheterization, prolonged NPO or bowel rest, probiotics as the ProPatria trial showed, Dr. Lawate already mentioned, and prophylactic antibiotics. They may lead to fungal infections. So finally, ladies and gentlemen, the two messages from today's panel discussion is patients who are elderly, obese, and have comorbidities should be taken extra care. Persistence of SIRS is the key. So that would help us predict in a very simplified manner at all levels of healthcare about the progression to severe disease. So SIRS has to be monitored repeatedly in a very meticulous manner. Goal-directed optimal fluid therapy. Prolonged fasting, bowel rest should be avoided. Enteral feeding should be started as early as possible, as Ruchir very beautifully explained why. 24 to 48 hours. If the patient cannot tolerate an oral diet by 48 to 96 hours, then NJ feeding is the choice. But NG could be good enough. So if you do not have facilities to insert NG is good enough. Prophylactic antibiotic in the first week should be avoided. Avoid folic catheterization. So I think I'll stop here, and If anyone wants to give their final comments, any of the panelists, any additional comments and points are most welcome.
Yeah. So, I mean, just the parting words, we have discharged the patient home. He has gone back happy, and everyone is happy and satisfied. We don't follow them up, or maybe they come to a surgeon or they come to a gastroenterologist who doesn't really usher in this concept of doing a glucose challenge or maybe an A1C. So this is what I just want to touch upon, the new onset diabetes after pancreatitis, the NODAP, like new onset diabetes after transplantation is very common. So this is the post-pancreatic diabetes, whether it's acute or chronic. 15% happens even with mild acute pancreatitis, and around 50% of this, severe necrotising, because you are actually digested all the, beta cells. The islets are gone. So within 3 to 5 years, they are bound to go into diabetes state, and all of them behave like type 1. So you shouldn't bother them with oral, anti-diabetics. You straight away think about a regimen of a type 1 basal bolus insulin that would heal them, because little bit of sugar up and down will again provoke from the reactive oxygen species to cause pancreatitis again. So, don't forget that diabetes can provoke reactive oxygen species, lipid peroxidation, and promote pancreatitis in a person who already has a setting of alcohol and other stuff. And they have concomitant obesity and hypertriglyceridemia. So please, all of us should remember this.
So on later note, we always tell our residents that for a patient like this to recover, both the doctor and patient need luck. And I think doctors,
that's very true. Yeah.
Of luck. Otherwise, it was an impossible situation. Wonderful case. And absolutely day to day what we see in clinical practice.
Thank you. Anand, do you want to say something? Parting words?
Only the issue is I just want to say as a critical care aspect, because generally we are receiving only the 1/10 of the patient or 1/8 of patient, because 15% patient are landing up in the ICUs. If those only physicians, those are referring to the centers, please, as much as you can resuscitate or refer as early as possible if you don't have a center, if you can't manage. The small things which can pick up the severity, which is a very, very commonly, just as I said earlier, urea and the hematocrit. If say patient is a severe acute pancreatitis, don't resuscitate with the aggressive fluid. Medium resuscitation is okay. If not able to maintain the blood pressure, maintain with the vasopressor in spite of giving the more fluid. You are more fluid, more harm. So this is only the take point, sir. I say.
Arun?
Sir, as a surgeon, the only surgery that I would be happy doing in the first 4 weeks would be maybe a laparoscopic cholecystectomy. Remaining all I would do only when I'm pressurized into doing them. The surgeons kindly don't jump into operating the first 4 weeks.
Sometimes we do pressurize our surgeons, Rohit Dama. We have a situation like this where the patient is like hanging. So, and then there is always a tussle, to wait or not to wait, and as conservative as possible. I know these are tough situations. And finally, Ruchi, anything from your nutritional?
I think he's facing some network issues.
Okay, no problem. So before we part, before I hand over to organizers, there are 3 questions actually. Dr. Chiranjeevi Gowda has asked the question: amylase level is more sensitive, right? No, it's the lipase which is more sensitive. Lipase stays in the circulation for a longer time, and it's more sensitive. So it should be lipase. If you have to select one between amylase and lipase, it's the serum lipase. Urine amylase may come up, but it's not yet used routinely. Dr. Atanu Haldar is asking about the size of microartery, less than 3 millimeter. And Dr. Himanshu Suya, what about urinastatin? We do not have strong enough data to support the use of urinastatin in the routine practice of acute pancreatitis. So I think I'll thank all the panelists for your brilliant output and brilliant participation and contribution. And I'll hand over to the organizers now. Pradipta, if you are there, you can take up, or Javeria.
Thank you, sir. I'll take up with the vote of thanks. I take this opportunity to express my thanks to Dr. Rupjyoti and all the eminent panelists for deliberating such a excellent deliberation on this topic. I express my gratitude to all the delegates who took out some time from their busy schedule and to be a part of this discussion. With this webinar today, we are initiating the series basically of knowledge sharing webinar. The recent upcoming webinars will be on 21st December 24 and 18th January 25. I extend my invitation to all for the same. The session was powered by our brand, that is Enzelo, which is a brand of pancreatitis 25,000 and 10,000, which is internationally Enzymax millimicrosphere technology. Okay, so we look forward for your support for Enzelo. Good night, sir, and thanks to everybody for participating and deliberating. Thank you, sir.
Thank you very much. Thank you, the entire
Thank you.
panel. Thank you.
Thank you.
Thank you, Dr.
Thank you.
Rupjyoti.
Yeah.
Thank you.
Thank you to
Thank
all
you so
doctors.
much.
Thank you, sir.
Thank you. Yeah. Have a good weekend and a good night.
Thank you, sir.
Same to you,
Bye-bye.
sir. Thank you.
Same to you, sir.
Bye. Chalo. Dr. Neeraj Jain. Dr. Neeraj Jain.
No, yes, actually,
Yeah, but
during the presentation also. it was-
I know. Thank you, Dr. Neeraj Jain, sir. Thank you very much.
नहीं. चल हार्दिक, कार्तिक,
Yes, sir.
डॉक्टर नीरज जैन को फोन करता हूँ.
Yes, sir.
हेलो. कार्तिक लॉग आउट कर दे. हेलो.
Okay, sir. Okay.
हाँ ये तो है. भरत.